almost all the subjects, but nephrology maybe we can try even more permutation combinations. So as with most of the chapters, placing in the pocket is very important here. Neuro we did element and human separately because you can't club them and do it together. For a subject like nephrology, placing it is extremely important because then only you know what are the syndromes, what to expect out of that syndrome, and accordingly as per the syndrome answer. Because in nephrology, you are not going to get very simple, straightforward one-liner questions. They're going to be very hard and very far and few that may be mostly related to patho. But medicine side questions are going to be having some kind of a clinical clue inside that. That's going to be the way the question is. So how do you place the disease in the pocket? So as far as nephrology is concerned, this whole disease is about understanding the anatomy properly. If you look at the kidney per se, there are three compartments. 85% of the kidney is made up of tubules and interstitium. That's what we call as the tubulo-interstitial compartment. 15% or so is remaining made up of 10% the glomerulus and 5% or so vascular. So these are the three major compartments as far as the kidney is concerned. So if anybody is asking you what is the kidney made of, means this is what the kidney is made of. That is why many a times students tend to get foxed by this term, no, CKD. What is the meaning of CKD? So if you just see what the pathologist is talking about CKD, you will understand what is CKD. CKD is equal to IFTA GS as far as the pathologist is concerned. What is the meaning of IFTA GS? It means interstitial fibrosis and tubular atrophy. Okay, interstitial fibrosis, tubular atrophy with glomerulosclerosis. So interstitial fibrosis, tubular atrophy and glomerulosclerosis. This is what we actually call as CKD. So what is the meaning of that? The interstitium and the tubules have become fibrosed or atrophied. That means that any disease process that starts anywhere in the kidney, finally the tubulointerstitium has to be atrophied and there has to be tubulointerstitial fibrosis to actually call it as chronic kidney disease. So you say chronic kidney disease, this is what you understand, and this is one major understanding that comes out of this. And also we know that chronic kidney disease for a lay person is equal to decrease in the number of functional nephrons. Correct? Decrease in the number of functional nephrons. So I can say some disease process has caused a decrease in the number of functional nephrons. What is the importance of that? If you look at the main function of the kidney has so many functions, but the integral function which everybody knows is filtration. So that's what I call as my glomerular filtration rate. My glomerular filtration rate, if you actually look into, is single nephron GFR into number of functional nephrons. So single nephron GFR into number of functional nephrons. So when I am having a decrease in the number of functional nephrons due to whatever cause it be, diabetes or whatever it be, then my single nephron GFR has to increase. Only if my single nephron GFR increases can I maintain the GFR. So for a large period of time, what will be the compensation? Single nephron GFR increasing. This single nephron GFR increasing is basically what is called as your hyperfiltration, and this is called as a hyperfiltration injury. So this hyperfiltration injury is very, very, very important to understand, because actually speaking, the starting point itself is a hyperfiltration injury. So hyperfiltration injury means what is the problem with this hyperfiltration injury? Hyperfiltration will raise the intraglomerular pressure, or what we call as the intraglomerular hypertension. This intraglomerular hypertension can actually alter the capillary pore diameter. Yes, it can alter the capillary pore diameter. And once it alters the capillary pore diameter, the chief villain will actually start coming into the urine, which you will see. And the chief villain coming into the urine is protein, and that is what is called as your proteinuria. So the reason for proteinuria in a CKD kind of setting is basically the fact that there is intraglomerular hypertension, there is altered capillary pore diameter, and that is resulting in proteins coming into the urine. If proteins come into the urine, what is the problem? Proteins are essentially very, very highly tubulotoxic. They're extremely tubulotoxic, and they will set up interstitial inflammation. So they are tubulotoxic and they will set up interstitial inflammation. And as a part of this inflammation, the kingmaker is released. Who is the kingmaker? TGF-beta. Okay, and you know, wherever there is TGF-beta in the body, there is fibrosis, and this fibrosis is essentially what we call a CKD. So if you understand the major problem in nephrology, the pathogenesis, if you understand, then rest of the things are going to be very, very easy and very, very simple, which means that CKD is essentially just a decrease in nephron number. Or if I'm asking you to tell me what is CKD for each person, if you ask a lay person what is CKD, he say kidney is not working, then you have to correct him. That's not the meaning of CKD. CKD literally means that there is a decrease in nephron number. Kidney is not working can come in so many different settings. I can take an NSA tablet and because of that my kidney may not work. So that is not what is CKD. CKD is a decrease in nephron number. If a first year MBBS student asks you what is CKD, you must be telling him that there's a decrease in nephron number due to which the remaining nephrons are overactive. This is called hyperfiltration. That can cause an injury. That's called CKD. A final year MBBS student is asking you what is CKD. You must tell him this hyperfiltration is leading on to intraglomerular hypertension. That is leading on to proteinuria. And proteinuria is the reason for CKD because proteins can actually cause interstitial inflammation and actually lead on to tubular atrophy. If a house surgeon is actually looking out for what is CKD, this is the perfect understanding. A very simple way. PG is looking for an understanding that may be even more complex. Then we have to talk of endothelial, mesangial, porocyte, crosstalk, this and that, and so many things. But here all that is not relevant. This is the only thing that you actually need to be knowing. So if you actually ask me what is CKD, you can place it in this way, very easy. And that is why the first major syndrome in nephrology is actually speaking chronic kidney disease. So when I sat for my MBBS level, we had a gold medal exam in nephrology. So that gold medal exam, I was asked this question: what are the 8 syndromes in nephrology? So when I was suddenly asked what are the 8 syndromes in nephrology, I got confused because I knew only 2 syndromes, that is nephrotic syndrome, nephritic syndrome. I didn't know any other syndrome, but there are actually speaking 8 syndromes in nephrology. And this time around, we will see those 8 syndromes and the possible questions that can come out of those 8 syndromes, and thus discuss the whole chapter. So one of those syndromes is actually speaking CKD. So CKD is one such syndrome, okay, which means that here we are actually talking of a decrease in the number of functional nephrons. Correct? Decrease in the number of functional nephrons. Decrease in the number of functional nephrons is leading on to proteinuria. This proteinuria is actually responsible for interstitial fibrosis, tubular atrophy, glomerulosclerosis. This is a very simple way that you can actually think of CKD in very, very routine terms. Okay, so this is one syndrome. The other syndromes also we will see. The moment you think of CKD, the major 4 causes for CKD have to come to mind. I'm writing 1 and 2 because these are the 2 major causes. The first one is diabetic nephropathy, which is the most common cause for CKD worldwide and India everywhere. Second is a glomerular disease producing CKD, which is called as chronic glomerulonephritis. Any glomerular disease can produce CKD. So diabetic nephropathy and CGN are the 2 most important conditions which can actually produce CKD. So when you think of CKD, the 2 major causes that come to your mind are diabetic nephropathy and CGN, and both are going to be characterized by extreme degrees of proteinuria. So this is essentially how you think of. This is essentially what you talk of. And in CKD as a disease, there are 2 things which are very important. One is calculating the GFR, okay? One is estimating the GFR, because GFR will actually tell you as to whether the CKD is in stage 1, 2, 3, 4, 5, what we call as G1, G2, G3, G4, G5. So as in when you think there is a CKD, this is very, very important. Doing an ultrasound is also very, very important because these are 2 things that are going to give you further data on what that needs to be done. So estimating the GFR right now is with the help of this MDRD equation. Okay, or CKD EPI equation. Both are equations, but CKD EPI equation can be considered as a touch better. So in this equation, what are we actually looking for? We are taking into consideration the age of the patient. We are taking into consideration the serum creatinine of the patient. We are taking into consideration the sex of the patient. We are taking into consideration the race of the patient. So these many things we are taking into consideration. Body weight is not being taken into consideration. That's very, very important. The olden equations had body weight, but right now we are not using body weight. Race, age, creatinine, and sex of the patient are taken into consideration. When your GFR is less than 15 ml per minute, that is what we call as G5, that is end-stage renal disease. It is when uremic symptoms are all start to appear. When your GFR is between 15 to 29, we call it as G4. 30 to 59, we call it as G2, G3. 60 to 89, we call it as G2. And more than 90, more than or equal to 90 is called as G1. So more than or equal to 90, G1, 60 to 89, G2, 30 to 59, G3, 15 to 29, G4, and less than 15, G5. So more than 90 is G1, but still you have a histological or biochemical or radiological evidence of kidney disease. So histological or biochemical or radiological evidence of kidney disease is there, but still your GFR is normal, that is called as G1. So this is G1, 2, 3, 4, 5. So actually calculating GFR is extremely important, which we can do with the help of our app, and you can't basically calculate this in your exam. This is the first thing that you have to be doing, that is to calculate the GFR. Second thing is to look for the ultrasound, because ultrasound is very important. The moment you are having a CKD, either the kidney size will become less than 8 centimeters. Okay, less than 8 centimeters, or it will be 8 to 10 centimeters with a loss in AMD. So 8 to 10 centimeters with a loss in CMD or less than 8 centimeters is what you're looking for. But remember very clearly that diabetes, HIV and amyloid are three conditions that you have to specifically remember where there can be a CKD with a normal size kidney. So CKD with normal size kidneys or even enlarged kidneys you can get. Normal size to enlarged kidneys you can get in diabetes, HIV and amyloid. So 8 to 10 loss in CMD everywhere, but diabetes it can be 11 with loss in CMD, 12 with loss in CMD, that is also possible. Okay, so that kind of an understanding if you have, then you know that, okay, this was syndrome, I'm in reasonable position to tackle. But here comes the only tough question out of this. The tough question out of this is, you are getting a question. Okay, this is a 52-year-old female, okay, 52-year-old female who has a history of being treated for sarcoidosis, okay, history of being treated for sarcoidosis since the last 15 years. Okay, history of being treated for sarcoidosis since the last 15 years. Numerous drugs have been tried in her. Starting from steroids. She's been given methotrexate, she's been given azathioprine, she's been given anti-TNF. So many drugs have been given in her. She gives you creatinine reports which were done maybe 3 years ago, 4 years ago. So they were all normal. So serum creatinine in 2018, 2019, they're all basically normal. And she's having nil symptoms also. Correct. Now this time around, because of a sarcoid skin lesion, she's actually gone on and checked again with the doctor. So now she is having fatigue. And as and when she said fatigue, they looked for a CBC which showed a hemoglobin of only 7.1 gram per deciliter. Total count, platelet count, everything was actually normal. They did a urea value came as 164 and creatinine value actually came as 5.7 milligram per deciliter. You again ask her, apart from fatigue, she doesn't have any major symptoms. And ultrasound actually showed small kidneys. When they did the urine actually showed, and creatinine value actually came as 5.7 milligram per deciliter. You again ask her, apart from fatigue, she doesn't have any major symptoms. And ultrasound actually showed small kidneys. When they did the urine actually showed albumin, that is trace, and deposits are not, no RBCs, nothing. So nil deposits, albumin trace is what you have seen in the urine. So this is the classical question that you get for the exam. Now, why I'm actually taking this question now and discussing is because we have already seen as to what is the meaning of CKD. So I'm telling you that whenever you get a clinical question in nephrology, we have to put it in any of the syndromes. It will be in one of the syndromes. And identifying the syndrome and then going behind the syndrome is how you answer a clinical question in nephrology. So any question in nephrology, and with that we learn also. So in this question, it is actually speaking very evident that they are asking for which syndrome. They are asking for the syndrome called CKD. Correct. But they have not given the biopsy interstitial fibrosis tuberculosis. They have not given because the kidney is actually very small. And when the kidney is very small, can you do a biopsy and say you cannot do a biopsy? So when you can't do a biopsy, this is enough to say that there is CKD. So ultrasound is coming small kidney, so the diagnosis is CKD. Correct. I am telling you again that when the diagnosis is CKD, in this question also, there can be only 4 options. What are the 4 options? First 2 options which you've seen, diabetic nephropathy, diabetes mellitus causing CKD, and chronic glomerulonephritis causing CKD, which can be a membranous, MPGN, IgA, anything for that matter. CGN is most often due to IgA nephropathy. Okay, 3 and 4 cause of CKD is vascular CKD. Vascular CKD is what we call ischemic nephropathy. So vascular CKD because of an artery issue going on and developing CKD, that is called as ischemic nephropathy. And then we can have a disease process which primarily starts in the tubulointerstitium, causing fibrosis of the tubulointerstitium. That is called as chronic tubulointerstitial disease or CTID. So diabetes is one cause, CGN is another cause, vascular is another cause, chronic tubulointerstitial disease is another cause. So like that, we are having 4 major causes for CKD. So 4 major causes for CKD, 1, 2, 3 and 4. Autosomal dominant polycystic kidney disease, I am not bringing into discussion here because autosomal dominant polycystic kidney disease is actually speaking under CTID, it comes under tubulointerstitium. So that's why I am placing. So these are the 4 options, and for the exam also, either other syndromes will be the option or these among 4 options of CKD will be the option. So when you get a question like this, you know it is CKD. So other syndromes are all out. We don't have to think of any other syndrome because ultrasound is given. If IFTA-JS is given, ultrasound is given with loss of CMD or a small sized kidney, and you are having basically nothing else to think of, you're actually getting CKD. So that can make you maybe think a little bit more, correct? Why is that the patient is not having any symptoms? Or is it that CKD doesn't present with symptoms, or CKD doesn't have symptoms, or is that the way that CKD presents? So that can be a confusion which many students can have. Let's try to dig a little deep into that. If a patient has CKD, what sort of symptomatology can he have? So let us start off with the commonest cause, which is a diabetic patient. So diabetic patient at diagnosis can never have CKD. It's only after a period of time that you are going to get CKD. The only diabetes where at diagnosis itself, the patient will have an impairment in renal function is pancreatic diabetes, okay, which is called type 3C diabetes. That is a rare exception, where in pancreatitis, alongside with that, you will be having a CKD also, or creatinine will be high. Otherwise, every time there will be a time span. Okay, so generally it is 5 to 10. Years. So 5 to 10 years is what is expected in the question paper also. So history of diabetes for 5 to 10 years is something that you're expecting. But never be ever be foxed. You can get non-diabetic renal disease also in a diabetic patient. So when you are expecting to answer diabetic CKD as the answer, you need 4 or 5 things to perfectly fit the bill. So if you are expecting to answer it as diabetic CKD, what is that you have to be looking for? First and foremost, the presence of edema. Without edema, there is nothing in diabetes. Okay, so the moment you are thinking of diabetes with CKD, extravascular edema is what we are looking for. So you need to be having evidence of edema, that is pedal edema, and the patient should be having progressive edema. Initial edema only on traveling, initial edema only on doing activities, getting up the stair, late edema every time. So that edema component has to be very well taken care of. Then proteinuria. Always patient will have proteinuria. The moment you are not having proteinuria and you're thinking of diabetes means that's a big mistake. So proteinuria is not going to be like an albumin trace or 1+. You are, if you're seeing, means 2+, 3+, and generally it is going to be a nephrotic range of proteinuria. So this is another very important question. What is the most common cause of nephrotic range proteinuria? The answer is diabetes. Nephrotic range proteinuria means more than 3.5 grams in 24 hours. Okay, at the same time, you have to keep in mind that diabetes will never have nephrotic syndrome. So if you're given the option nephrotic syndrome, then you should never answer that, because nephrotic proteinuria is different, nephrotic syndrome is different. Nephrotic proteinuria and edema are two components of nephrotic syndrome, and I perfectly agree. But nephrotic proteinuria with edema, with hypoalbuminemia, hypercholesterolemia is what we call as nephrotic syndrome. So nephrotic syndrome and nephrotic range proteinuria are two different entities. So here the patient can have edema, that is a progressive edema. It's not like an edema that is developed over 2 or 3 weeks like nephrotic syndrome. Here it is like a progressive edema, proteinuria is there, nephrotic syndrome is absent. And also macrohematuria is always absent. You can never get macrohematuria, you can never get microhematuria. Same way you can never get hypoalbuminemia and hypercholesterolemia. So if you see any of these questions, any of these options, then you are basically out of it, because in diabetes, it is going to be edema and proteinuria. Yes, and that is why this history of frothing of urine is very important. The patient will give you this long-standing history of frothing of urine, progressively frothing. If it is another glomerular disease causing frothing, it will be a very short duration, then coming as nephrotic syndrome. Here it is not like that. And then of course, diabetic retinopathy. Diabetic retinopathy goes hand in hand with diabetic nephropathy. In type 1 DA mature level, you can say 100% patients will have retinopathy by the time they develop nephropathy. And in type 2 DM, you can say around 65% patients will have retinopathy by the time they develop nephropathy. So retinopathy, frothing, edema, proteinuria, and hypertension. Hypertension will also be given as a definite mandatory option. So when you see these many things together in the case of a diabetic patient, and then you are getting a CKD picture, that is when you answer I answer it as diabetic nephropathy. So first you try to fix the syndrome. What is the syndrome? CKD is a syndrome. You know when to say the answer is CKD. Once you know CKD is a syndrome, then there are only 4 options possible. First option is diabetic nephropathy. Second option is CGN. Third option is CTID. Fourth option is vascular. If you know this, then you know whether it is diabetes or not. Okay, so in this particular case, can we actually fix it up as diabetes? There is no way in the world that we can fix it up as diabetes. So diabetic nephropathy is out of this. What remains? CGN, vascular, or CKD. Even if this was given that this lady, because of taking steroid, was a diabetic for the last 5 years, still when you answer it as diabetic nephropathy, never should you answer. That's where many students go wrong. First and foremost reason is there is no proteinuria significant given, there is no edema significant given, there is nothing like hypertension significant given, so frothing is not there, nothing is there. Okay, another complication of diabetes like retinopathy, nothing is given. So when all these things are not given, me to mark it as diabetic nephropathy would be a total blunder. Yes. Now we go to the second option. What is the second option? Second option is this a case of chronic glomerulonephritis? Is it possible that way? Chronic glomerulonephritis is an end-stage complication of a glomerular disease, most often IgA nephropathy. So it's an end-stage complication of a glomerular disease that is most often IgA nephropathy. So naturally, initially getting diagnosed as IgA, so many times being treated for IgA, slowly creatinine increasing, slowly proteinuria increasing, and then slowly going into CKD is the common thing that you can see. For your exam, can you get a symptom presentation of CGN? Yes, you can get a symptom presentation of CGN when a patient actually comes with edema, proteinuria, hypertension. So hypertension is not like more than 200 etc. but still 170, 180. So edema, proteinuria, hypertension combo is what the patient is coming with. If you ask them again, they will be having frothing for some time. If you ask them again, they will be having fatigue for some time. And these patients tend to be living with this for some time. Suddenly they come to you one day, mostly with uremic symptoms. So that is how they present to us mostly. And the most classical uremic symptom is this vomiting. So they come to you with uremic symptoms. Most classically they come with vomiting. Then you see edema, you see proteinuria, you see hypertension. Then you check the creatinine. Creatinine will be coming as 7.5. And then you look for the ultrasound. Ultrasound will show actually small kidneys or 8 to 10 centimeter kidney with loss in CMD. And then you know that the diagnosis is mostly a CKD. And when inside CKD, what else can you keep? You cannot keep diabetes. You have edema, proteinuria. So once again, you have to keep the diagnosis in the glomerulus. And the glomerulus diagnosis is CGN. Okay, so that is how you fix on the diagnosis called chronic glomerulonephritis. Edema, proteinuria are part and parcel of glomerular diagnosis. The moment you get edema and proteinuria, that is equal to glomerulus. You cannot place it in the vascular compartment. You cannot place it in the tubulointerstitial compartment also. Hypertension can be seen in glomerulus and vascular, but profound hypertension is generally seen in vascular compartment. Okay, so this is how you place this. So this also in this particular case, is it right or wrong? No, this is completely wrong because we don't have any significant edema, we don't have any significant proteinuria, we don't have the patient coming with profound hypertension, even BP has not been mentioned. So all that means that this is again very unlikely to be a case of chronic glomerulonephritis, which means that now vascular remains, CTID also remains. Vascular means a patient with renal artery stenosis becoming CKD. A patient with renal artery stenosis becoming CKD. So when you have a patient with renal artery stenosis becoming CKD, naturally you will be given a case of smoking, CAD or POVD. All these things are going to be there because it is a vascular issue. So multiple other vessels are going to be involved. CAD history, POVD history, everything will be there in the question. And also very importantly, the kingmaker has to be hypertension. It is a hypertensive episode that actually brings the patient to the doctor. Smoking is there, CAD is there, POVD is there. And all that is going to be there. Vascular means, again, urine will be having, as very correctly said, trace to 1+ of proteinuria only. No RBCs will be there. Edema also won't be there. So that is perfectly fine. That you can actually say. But again, keeping in mind that this is not a picture. First and foremost, this is not a picture because hypertension is not there, vascular disease history is not there, smoking is not there, CAD is not there, POVD is not there, BRUI is not there, peripheral pulses have not been told about. So we basically don't want to think about vascular or ischemic in this case. Okay, so the only thing that actually comes to my mind right now is, can this be a chronic tubulointerstitial disease? Is everything fitting the bill for a chronic tubulointerstitial disease? What is the meaning of a chronic tubulointerstitial disease? Chronic tubulointerstitial disease means slow bilateral fibrosis. Okay, slow bilateral fibrosis. That is what it is. Very slowly, the tubulointerstitium is getting fibrosed. Sometimes we know the cause, sometimes we don't know the cause. And we often call it a CKDU or CKD unknown when we don't know the cause. The causes that we actually know are primarily related to drugs, of which lithium is a culprit, calcineurin inhibitors are culprits. Okay, nowadays we say that even PPAs to an extent are culprits. Then of course we know about few autoimmune conditions which can produce CTID, including IgG4, including sarcoid, including Sjogren. So IgG4, sarcoid and Sjogren. Then we know about few inherited conditions which can produce CTID, especially this AD, PKD, and medullary cystic disease of kidney, MCDK. Okay, then we know about reflex nephropathy. which can actually produce CTID. So reflex nephropathy, which can produce CTID. So drugs are there, autoimmune is there, inherited is there, reflex nephropathy is there. These are the major things that actually come to your mind when you think of chronic tubular interstitial disease. But chronic tubular interstitial disease, many a times the problem is we really don't have a cause. We are not able to figure out the cause. If you look at the kind of workup that we will be doing for a chronic tubular interstitial disease, obviously we'll be seeing for the drugs, as the drugs can produce CTID. Inherited causes, of course, will be actually very straight and plain with respect to their presentation. Autoimmune causes, especially IgG for sarcod and Sjogren, these are the three conditions which involve the tubular interstitium more, in contrast to an SLE, etc., which generally doesn't involve the tubular interstitium, which involves the glomerulus mostly. And then, of course, reflex nephropathy, we can have obstruction also presenting like this. Yes, obstruction also having a CTID picture. And metabolic conditions, that is hypercalcemia, hypokalemia, hyperuricemia. Okay, and hyperoxaluria. So hypercalcemia, hypokalemia, hyperuricemia, hyperoxaluria. These are, in short, the 6 major causes for chronic tubular interstitial disease. In this particular case, sarcod is being given. Yes, urine analysis shows only albumin trace, so no proteinuria, no microhematuria, nothing. The very word called hypertension is not described. Everywhere else in glomerulus and vascular, we talk of hypertension. Tubular interstitial, there is nothing called hypertension. So very easily, we are able to bring this down to chronic tubular interstitial disease. Okay, so I think this part discussion is actually speaking very clear. And what are the key points about a chronic tubular interstitial disease? The key points about a chronic tubular interstitial disease are: 1, very slow onset. 2, complete absence of symptoms. Complete absence of symptoms. If you keep on asking the patient also, what symptom did you have? Nothing, they will say. At the most, if you keep probing, they may tell you polyuria and nocturia, because these are all got to do with concentrating capacity, which is lost. And the symptom which brings the patient to the doctor is fatigue. And that fatigue is because of disproportionate anemia. And the disproportionate anemia is because of erythropoietin deficiency. And because erythropoietin is produced from the cortical peritubular interstitial fibroblasts. Okay, cortical and outer medullary peritubular interstitial fibroblasts. So this is the next presentation. And just like that, when you take an ultrasound, ultrasound will show bilaterally small kidneys. Ultrasound will show bilaterally small kidneys. And number 5, what are you going to see? You're going to see the urine. And urine is mostly called as bland because there is no sediment, nothing. Albumin will be traced to 1+. Okay, because the tubular interstitium is getting involved here, the patient will have problems with respect to concentrating capacity, correct? That is one thing that you have to keep in mind. That's why they present with polyuria and nocturia, and many times have a peripheral DI-like presentation, peripheral diabetes insipidus-like presentation, because they'll be keeping on passing water diuresis, or they'll be keeping on having water diuresis. Another thing that you can actually keep in mind is the metabolic acidosis. Again, because of lack of tubular interstitium, lack of excretion of H+, you can have metabolic acidosis. This metabolic acidosis is mostly renal tubular acidosis, which we will see, and it's a type 4 like RTA, which you see in a tubular interstitial disease, RTA type 4. And because it is RTA type 4, they can have hyperkalemia. And this hyperkalemia is again very important, which we will see. Hyperkalemia, whenever you are having a disproportionate hyperkalemia to the degree and duration of kidney disease, you always have to think of a RTA4. We will see what is RTA4, and in RTA4 it is hyperkalemia. RTA1 and 2 is hypokalemia, RTA4 is hyperkalemia. RTA4 is typically associated with chronic tubular interstitial disease, and this chronic tubular interstitial disease will present with disproportionate hyperkalemia. So the major angles that you have to look for in this question are: 1, anemia. This is one very important angle that you have to see. Second is absence of proteinuria. Very important angle to see. Third, small kidneys on ultrasound. Very important angle to see. 4, the presence of water diuresis, which is very similar to a DI-like kind of thing. 4 is the RTA, which is like RTA4. And most importantly, hyperkalemia, which is disproportionate. And the reason we will see. Okay, so we have tried to place this in that particular pocket. So in this particular opening module discussion, I'm just trying to discuss about a case of CKD that can come to you. And in that case of CKD that can actually come to you, how do you place the disease in the right pocket? So as far as CKD discussion is concerned, there are only 4 things to keep in mind: diabetes, CGN, vascular, what we call as ischemic nephropathy, and chronic tubular interstitial disease. And how each one presents to you is very clear. A patient with a history of diabetes, you should never think that it is diabetic nephropathy. You must think of diabetic nephropathy only with the duration, with these kind of symptoms like edema, with frothing, proteinuria, hypertension, retinopathy, and the absence of a nephrotic syndrome presentation, absence of hematuria, absence of hyperalbuminemia, hyperlipidemia. That is only when you must be thinking of diabetic nephropathy. CGN presentation is already known glomerular disease, or for the first time presenting with edema, proteinuria, hypertension, anemia, you can think of, but no disproportionate anemia. Vascular means all the history of CAD, smoking, POVD, other coronary disease, everything will be there. Along with that, no much of edema, no much of proteinuria, no RBCs, nothing in urine. And CKD is going to be completely asymptomatic presentation. Okay, so that is actually how you come to place the disease in the pocket in a CKD question. So once again, trying to tell you that the first major syndrome in nephrology is always a chronic kidney disease, which you identify on the basis of ultrasound in your question paper with loss in size or loss in CMD. And of course, you also calculate the GFR to say what is the stage of CKD, and less than 15 is stage 5. If you want to place the disease in the pocket, of course, glomerulus is the first thing that you think of, and two things are glomerulus, diabetes, and CGN. And I told you the two major things about glomerulus are proteinuria and edema, which you have to be very, very sure with. Suppose this is not there, then you can place it in the vascular pocket, where you'll be having proteinuria only trace or 1+, and of course, no edema. But a very, very important finding is going to be significant hypertension, much more than the glomerulus compartment. And there you have other history like CAD, POVD, smoking, and all that. If both these are not fitting, and when there is proteinuria trace and no edema and no hypertension also, so then the very easy pocket to place will be the tubulointerstitial pocket, and the CKD in the tubulointerstitial pocket is called as your chronic tubulointerstitial disease. So this is how you place the disease in the pocket in the first syndrome, and that is CKD, and that's what we have tried to see over here. So we're going to the second of the modules under nephrology. So I told you, whenever you get a nephrology related question for your exam, the first priority of ours is to see whether CKD is there or not. So CKD is there or not. In that case, it is CKD. If CKD is not there, that is when we start evaluating more and more. So now we're going to come to a scenario where there is actually speaking no CKD. Let us see how this can pan out. Now I'm trying to give you two cases here. Okay, two cases here. This is a 66-year-old male who is actually CAD post-angio, right? Who is also a chronic smoker. Okay, CAD post-angio, who is also a chronic smoker. This patient is also a hypertensive for a long time, and is on drugs. Okay, on drugs. Correct. This patient baseline creatinine previously was checked to be 1.9 milligram per deciliter, 1.9 milligram per deciliter. Okay, and his ultrasound was showing kidney size which was 7.2 and 7.3. So 7.2 and 7.3, creatinine was 1.9 that time, and urine albumin was actually trace and no deposits. Okay, this is the scenario. Correct. In this particular scenario, he is now coming and seeing you with a creatinine of 3 milligram per deciliter. So he's coming and seeing you with a creatinine of 3 milligram per deciliter and no major symptoms. So no major symptoms. Correct. Yes. There is a 23-year-old male, as what has happened even last time, who has come with a real panic attack, okay, who has got a proper panic attack at night. And because of the panic attack, headache and flushing and sweating and diaphoresis and all that, was brought to the hospital. BP at the time of panic attack was very high. And even after the panic attack, BP continued to be 220, 100 millimeters of mercury. In spite of giving many drugs, it's still 220, 100 millimeters of mercury. That is when we thought of taking the RFT. RFT was urea 106 and creatinine 3.1. So urea 106, creatinine 3.1. Ultrasound was showing normal size kidneys. Urine was showing albumin trace and nil deposits. Okay, and he was having no edema. But he is giving you history of headache, which is most likely to be due to hypertension. So he's giving you history of headache, which is more likely to be due to hypertension. So these are two patients. Now you have to see these two cases. And with these two cases, you must again tell me what you have understood. This is case number 1. In case number 1, straight I am going into the ultrasound because I want to fix the syndrome first. So I will fix the syndrome that this is a CKD. Okay, that's a CKD. Very clear. Case number 2, I'm having ultrasound normal sized and I'm having nothing suggestive of CKD. So I can place it as not a CKD. Don't say AK. Okay. There are so many syndromes, 8 of them I told you. What is CKD and the other is not a CKD. Not a CKD, there are so many things again. So once you place this as CKD, then I'm asking you the simple question. Is it a vascular CKD? Is it a glomerular CKD? Or is it a tubulointerstitial CKD? Correct? Vascular CKD, glomerular CKD, tubulointerstitial CKD. Okay, you have already seen that in the last module. Tubular interstitium is not going to present like this. It is going to be asymptomatic for a long period of time and going to have a disproportionate anemia, and there is no hypertension, no CAD, nothing like that. The very fact that CAD is given, smoker is given, vessel is what you are focusing, hypertension is already given, no proteinuria and edema to think of glomerulus, so it's a vascular CKD. So the first case is very easy. It is a case of ischemic nephropathy or a vascular CKD. Ischemic nephropathy, vascular CKD. Correct. It's a very simple question. When you come to question number 2, in this particular question, ultrasound is given as normal size, so it's not a CKD. When it is not a CKD, then you have to fix the compartment first and then think of the diagnosis. Okay, you have to fix the compartment first and then think of the diagnosis. First compartment vascular, second compartment glomerulus, third compartment tubular interstitium. So where do you want to place the disease? Okay, do we have to, I'm not telling you syndromes and anything, I'm just asking you where will you place the disease. Now, do we have so much of edema and proteinuria? So we don't have edema and proteinuria, so I'm striking off the glomerulus part. Will you ever get so much of high BP in a tubular interstitial disease? It's impossible to get such high BP in a tubular interstitial disease, so that also I'm striking off. So the only thing that is actually there in front of me in this question is a vascular kidney disease. Yes, this is a vascular kidney disease. Very, very important. And this vascular kidney disease can be which vessel, large or small, and all we will come to. And this has not become a CKD. So the diagnosis on this particular case is renovascular hypertension. So I can actually put it as renovascular hypertension, or I can even say vascular kidney disease, which has not become a CKD. Correct. Now, how do we approach this? So I'll just tell you one more way we can actually see the same case. Another way we can see the same case is that this is a young male who has come with a hypertensive crisis. Correct? Young male with more than 180, 110. It is a hypertensive crisis. In this hypertensive crisis, I would want to put it as a hypertensive emergency. Although he has not had any pulmonary edema, he's not had any CNS issues extra, but still the fact that he's come to the casualty for a namesake discussion, I'll put it as a hypertensive emergency. Any hypertensive crisis that actually comes to you has to be thought of as secondary hypertension unless proven otherwise, correct? And if pulmonary edema, he's not had any CNS issues extra, but still the fact that he's come to the casualty for a namesake discussion. Vascular kidney disease, which has not become a CKD. Correct. Now, how do we approach this? So I'll just tell you one more way we can actually see the same case. Another way we can see the same case is that this is a young male who has come with a hypertensive crisis. Correct? Young male with more than 180, 110. It is a hypertensive crisis. In this hypertensive crisis, I would want to put it as a hypertensive emergency. Although he has not had any pulmonary edema, he's not had any CNS issues extra, but still the fact that he's come to the casualty for a namesake discussion, I'll put it as a hypertensive emergency. Any hypertensive crisis that actually comes to you has to be thought of as secondary hypertension unless proven otherwise, correct? And every case of secondary hypertension is mostly due to renal or endocrine. And in this particular case, creatinine is high. Because creatinine is high, I want to definitely think of renal. Correct. And in renal, the first thing that comes to my mind is vascular, because hypertension is all about vascular. So this case, can I call it as a renovascular case? Yes, I can call it as a renovascular case. Okay, so that way also I can come to the answer. So whatever said and done, in this particular case, I'm thinking of vascular kidney disease. Okay, vascular kidney disease. Vascular kidney disease can actually be, most importantly, a large vessel related. So it can be very often large vessel related. Sometimes it can be small vessel related, so large vessel related or a small vessel related. Small vessel related is called as thrombotic microangiopathy. Okay, small vessel related is called as thrombotic microangiopathy or TMA. In this TMA, the prototype example is HUS. Okay, prototype example for TMA is HUS, hemolytic uremic syndrome. And in HUS, automatically the question paper should be having thrombocytopenia, MAHA, and then only renal failure. So thrombocytopenia, microangiopathic hemolytic anemia, and then renal failure. So the very fact that in this question paper you're not having thrombocytopenia and microangiopathic hemolytic anemia means that you are not looking at TMA. So you're not looking at TMA because TMA should be having thrombocytopenia, it should be having microangiopathic hemolytic anemia, so that is not there, which means mostly I'm dealing with a large vessel. Yes, mostly I'm dealing with large vessel. And this large vessel vascular kidney disease is what I call as renal artery stenosis. So this is what I actually mean by the term called renal artery stenosis. So this is how you will get a question for the exam on renal artery stenosis. Hope this is very clear. This is the second syndrome that we are actually presenting with. First syndrome I taught you was CKD syndrome. Second syndrome I'm talking to you is renovascular hypertension. In renovascular hypertension, if the kidney size is normal, it is mostly equal to a renal artery stenosis. The most common cause for a renal artery stenosis is atherosclerosis. Okay, most common cause for renal artery stenosis in young patients is fibromuscular dysplasia worldwide and Takayasu in India. But Takayasu has a 9:1 female-male ratio. So young male, if given in the question, it's more likely to be a polyarteritis nodosa. And FMD, if you have, you'll have this string of bead appearance. Okay, but FMD is very, very rare. It's not to be seen here, so nothing much to actually talk about. When you get a case like this, automatically you go for the CT renal angio or MR angio that can actually fix it up. And with this, you may have to go for a angioplasty and stenting, depending upon so many factors, which again are not at your level and not asked for your exam. But still, insights into that have been provided in the original discussion videos. But this is how you come to the case. Okay, so every time you come to a renal discussion, what is that you're thinking of first? Every time you come to a renal discussion, the first thing that you're thinking of is the CKD or not. If you think that it is CKD, you go along the lines of CKD and try to fix a diagnosis among the 4 causes of CKD. Suppose you think that this is not CKD, suppose you think that it is not CKD, then you have to fix a compartment. The one compartment you can always fix up is your vascular, provided the patient has significant hypertension, which is presented as a crisis, as an urgency or an emergency, or the patient has got significant vascular disease comorbidities with hypertension, with ischemia and all those things. But always remember that edema will be absent. Always remember proteinuria significant will not be there. The kidney size is small, you can call it a CKD ischemic nephropathy. If the kidney size is normal, you can just call it as RAS. Okay, renal artery stenosis. It means that there is some degree of reversibility possible. And I think in the original module, I had told about a case which me and my friend had happened to see, where a young girl, only 18 years of age, had come to the casualty with full-blown seizures, GTCS, and we did not know what is the cause for GTCS, and her BP was continuously about 200. So we knew that this was hypertension-related seizures. Her MRI showed white matter edema. There was a posterior reversible encephalopathy syndrome or hypertensive emergency. So we went behind the cause of hypertension, looked into renal endo, and creatinine was high, and it was actually a renovascular cause. And we worked her up for Takayasu arteritis, and she was having Takayasu. So that those kind of cases also, I think I had told you. So basically, it's about fixing the disease in the pocket. And now I think that you are confident enough to place this disease in that particular pocket, which is the vascular case. So vascular case will come to you only in these 3 ways. One is patient coming to you with a complication of hypertension, which can be dyspnea, which can be panic attack, which can be press or anything for that matter. And second, and with the creatinine high, and you know that you have to go to the vascular pocket, or a very elderly patient with CAD, OVD, smoking and all that, having no pulse, brewing and all those things. And that patient also having a vascular kidney disease. If kidney is small, we call it as a ischemic nephropathy. So this is how you answer this. But in a hypertensive emergency question, always have what in mind? TMA in mind, because TMA can also come like that. But specifically, you will be given what? Microangiopathic hemolytic anemia, thrombocytopenia, and all those things. This is the second syndromic discussion. We are coming to syndrome 3. So we're going to syndrome 3. Syndrome 3 is actually speaking a very, very serious that is a patient who presents to the OP with a hematuria. Again, repeat, hematuria coming to the OP. So no IP, no casualty, nothing. Patient is actually coming to with a hematuria to the OP. Right? How do you approach this? And hematuria patient coming to the OP has more often got a normal renal function test. It's got a normal renal function test. How will you approach this hematuria case that is actually coming to the OP? I'm giving you 2 patients. One is a 17-year-old boy. Second one is a 65-year-old male. So 2 people are here. both of them are having the same symptom. Both of them are having the same symptom. That is, for the past 1 week, they are actually seeing high colored urine. So for the past 1 week, they are seeing high colored urine. So this high colored urine is a very generalized term. It can be, red, brown, black, coffee color. All that is called as high colored urine. So they are having 1 week symptoms of high colored urine. So this is your syndrome 3 in nephrology. We're discussing those syndromes. That question is something that lurks in my memory so strongly because this was a gold medal exam and it was a team game, actually speaking, not a single person. So because it had so many formats and across it and last the quiz, etc. So we were the winners, me and my friend. So we both were the winners, and she went on to do medicine, and now she's an assistant professor at our own government medical college in Kerala. So I think that was the first spark that was actually ignited in me with respect to the subject, and I basically thought that, okay, this could be taken as an option with respect to my career, but I was not very clear about it at that time, but it somehow panned out to be so. So 17-year-old boy and 65-year-old male, both of them are there, both have the same symptom. So again, when we start discussing this, I think the prime facie concept that you have to be knowing is that 90% of people who come with hematuria have a urological cause for hematuria and not a nephrology cause. Only 9% of people who come with a hematuria have a nephro-related cause, and only 1% of them actually have got a hematological cause. So this is how it goes, which means that although we are discussing macrohematuria, the bulk of the causes under macrohematuria, whether it be stone or malignancy or urethritis or whatever, is all basically equal to a urological cause. So this we have to be very, very clear. Now, keeping this in mind, how will we start off our evaluation? When we start off our evaluation, it's basically urine analysis that we are actually doing, urine routine examination, and we're seeing for whether this dipstick is positive for blood or negative for blood. So generally, the dipstick will be positive for blood. If urine routine examination for your exam is showing dipstick negative for blood, then there is only one answer in the world, and that is porphyria. Okay, so if dipstick is negative, then there is only one answer, that is porphyria. Suppose dipstick is positive for blood, then automatically we go for centrifugation of urine. Very, very important, centrifugation of urine at 1600 rpm for 5 minutes. Okay, so 1600 rpm for 5 minutes. At the end of centrifugation, we are checking for whether the supernatant is clear. Okay, supernatant is clear. At the end of centrifugation, if the supernatant is clear, then it means that RBCs have given the color to the urine and RBCs have now settled down. So RBCs have now settled down and that the urine has become clear. Now supernatant has become clear. At the end of centrifugation, if the supernatant is still high color, okay, if it is still high color, then RBCs have not given color to the urine. If RBCs have not given color to the urine, it is hemoglobin or myoglobin that you are actually thinking of. Correct? So I think this is very, very clear now. So you have to first do dipstick, it is positive, then centrifuge. At the end of centrifugation, then you have to see for whether the supernatant is clear or not. If the urine becomes clear after centrifugation, then it is definitely equal to RBCs. They would have settled down at the bottom. If it is still high color, then it's either hemoglobin or myoglobin, which means that when you get a scenario like this, you are thinking of RBCs as one cause. You are thinking of hemoglobin as another cause. You are thinking of myoglobin as another cause. And you are thinking of porphyria as the third cause, fourth cause. Okay, and porphyria you know how to rule out very easily. Now comes the issue of whether it is RBCs. Now before we see whether it is RBCs, what are the other two conditions where you can actually get this? That is hemoglobin and myoglobin. That is why never ever forget this, that acquired intravascular hemolysis, okay, which you may miss many times. Acquired intravascular hemolysis can very often present with hemoglobinuria. So acquired intravascular hemolysis can very often present with hemoglobinuria. Correct. And that is why it's very, very important to actually keep the urine still for some time. Myoglobin has got a very short half-life, 3 hours, 4 hours like that. So in 3 to 4 hours time, the urine will clear off. Whereas hemoglobin means its half-life is longer, it will not clear off. So first you do centrifugation. If it becomes clear, it is if it becomes clear, it is equal to RBC. If it is still high color, hemoglobin versus myoglobin, just keep the urine still for some time. Myoglobin means it will clear off. If it is hemoglobin, it doesn't clear off. It's very simple. And in this context, if it is hemoglobin, acquired intravascular hemolysis is what you have to talk about. And in acquired intravascular hemolysis, drugs, toxins, infections, everything can produce this. But the single most important cause for your exam is paroxysmal nocturnal hemoglobinuria, PNH. Because PNH is that one disease where the patient can present with episodic early morning hematuria. I told you about the case of our student's mother who had this, and she was taken to the urologist first, who did ultrasound and CT and cystoscopy and all that, but still couldn't figure out a diagnosis. So that's how it is. So PNH is very, very important. Similarly, if your urine gets cleared, please check for CPK and think of rhabdomyolysis. Rhabdomyolysis is now becoming so very, very common to see, especially with people who tend to exert them unduly. We have doctors themselves getting admitted with rhabdomyolysis who basically don't go to the gym for a prolonged period of time, profound period of time. Suddenly one day go to the gym and get trained, not with a proper trainer, maybe by themselves, because of proper trainer won't allow this, and train for say 1.5 hours, 2 hours, and do resistance training and all that, and next day develop rhabdomyolysis. But in rhabdomyolysis, of course, in the question paper, we'll be having a very important symptom, that is muscle pain. Because muscle pain to get rhabdomyolysis is difficult. So rhabdomyolysis is the second thing that you have to keep in mind, and always check for your CPK, which will be coming in 10,000, 15,000, 20,000, etc. Okay, right. So that is hemolysis, rhabdomyolysis. Then if RBCs are there in the urine, suppose RBCs are there in the urine, then comes the issue. Okay, one, is it isomorphic RBC? Okay, with no proteinuria, no acanthocytes, okay, and no RBC cast. So isomorphic RBC with no proteinuria, no acanthocytes, and no RBC cast. This is what we mostly think of as a urological cause for hematuria. Okay, whereas RBCs which are dysmorphic, okay, more than or equal to 40%, more than or equal to 5% acanthocytes, okay, or even one single RBC cast. This is the famous 45-1 rule, or one single RBC cast with proteinuria. Okay, with proteinuria means that this is a glomerular cause for hematuria. So this is a glomerular cause for hematuria. Clear? And the 65-year-old male was most likely having what? A urology cause. And if you do an ultrasound next, you're most likely to see a mass. It may be a bladder mass, it may be a renal cell carcinoma, it may be urethral malignancy, anything. That 17-year-old boy is very likely to be having this. And he is most likely going to get what on the biopsy? IgA nephropathy on the biopsy. Okay, so glomerular hematuria is very often because of what on the biopsy? IgA on the biopsy. And accordingly, you take it from there, put a score for IgA based on your MES score and all, and you push on. But this is the basic approach to a macrohematuria presentation. This is the third syndrome in nephrology. So when you get a syndrome like this kind of presentation, so many permutation combinations have to come to your mind. As far as your exam is concerned, either it can be urology, stone, or malignancy, or it can be nephrology where NH, either it can be rhabdomyolysis due to any particular cause, mostly undue muscle exertion. Okay, I think this is basically the total roadmap towards hematuria, a total roadmap for hematuria. Now we're going to the fourth of the syndromes, which is nephritic syndrome, which some people also call as acute glomerulonephritis. Okay, nephritic syndrome, or acute glomerulonephritis, or just nephritis, whatever it is. So there are two parts to the syndrome. Okay, we can get a question in a child and we can get a question in an adult. So two questions are possible here. One is question in a child and the other is a question in the adult. When you think of question in the child, okay, there is only one thing that has to come to your mind, and that is equal to PSGN. Okay, only thing that has to come to your mind is PSGN. Adult means there is only one thing to come to mind, that is IRGN. So PSGN has to come to mind in a child, IRGN has to come to mind in adult. What is the meaning of PSGN? Post-streptococcal glomerulonephritis. Okay, what is IRGN? Infection-related glomerulonephritis. So it is post-streptococcal glomerulonephritis versus infection-related glomerulonephritis. Both are two different settings, and we'll try and see what is the key point with respect to each of these settings. So that's what is the important thing. So how will the child question be? So in this child question, what is very, very important for you to know is that the presentation is going to be extremely acute. So it's going to be very acute presentation. Nephrotic syndrome is not acute, it is mostly subacute. So this is acute presentation, and the child is going to come to you with a high-colored urine. So that way, you can actually start your approach in a very similar way. That means acutely when a child comes to you with high-colored urine following a skin infection or a throat infection, of its skin infection much more than throat infection. So acutely a child is coming to you with a high colored urine following a skin infection much more than a throat infection. That is a very high possibility. Okay, now we'll see. Whenever somebody comes with a high colored urine, automatically what do you look for? You see whether it is lipstick positive, negative, so is lipstick positive, RBC, or otherwise yes, here there is RBC, and you are going to see a very important finding here, that is your RBC cast. So the moment you are actually seeing high colored urine with the RBC cast in a child, which is a very acute presentation, okay, you are thinking that something may be possible, something may not be possible, etc. But a very important add-on is the presence of hypertension. Very important add-on is the presence of hypertension, and along with that, the child has renal failure also. So it is not like a normal RFT that you're talking of. This is a mildly altered RFT. So mildly altered RFT, not I'm saying creatinine 4 or 5, but 1.8, 1.9 like that. So altered RFT is there, hypertension is there, high colored urine is there, background of a skin infection or a throat infection is there. Then this is good enough to say that you are dealing with the acute glomerulonephritis, or what we call as nephritic syndrome. So very abrupt onset of high colored urine with hypertension, renal failure. You have to be very clear with the fact that proteinuria can be 1 plus here. It is generally 1 plus. It is not 2 plus and 3 plus, generally 1 plus. Edema can be there, but edema is not going to be very severe. It is going to be more of a mild edema, not going to be robust edema like in a nephrotic syndrome. And serum albumin levels are going to be normal here. Serum albumin levels are going to be normal here. Okay, this is the classical picture. And the child is going to be an immunocompetent boy. This is very important. He is not going to be immunosuppressed or anything, and he is most likely going to be a boy. 2 to 7 years is the classical age group that you're talking of. So 5-year-old child, etc., is what you are going to see, and that pyoderma on the skin following, which all that is going to be classically described. Now, in this particular case, 3 things deserve special mention. What are the 3 things that deserve special mention? Hypertension, renal failure, and intravascular volume overload. So whenever we talk of this disease called nephrotic syndrome, we talk of edema. We'll come to that. That is extravascular edema. In this particular condition called nephritic syndrome, the edema is due to overactivity of the epithelial sodium channel, because so many of the proteases that are being released by the organism is activating this epithelial sodium channel. Describe. Now, in this particular case, 3 things deserve special mention. What are the 3 things that deserve special mention? Hypertension, renal failure, and intravascular volume overload. So whenever we talk of this disease called nephrotic syndrome, we talk of edema. We'll come to that. That is extravascular edema. In this particular condition called nephritic syndrome, the edema is due to overactivity of the epithelial sodium channel, because so many of the proteases that are being released by the organism is activating this epithelial sodium channel, it seems. And because of that, epithelial sodium channel reabsorbs salt and water, and you are likely to have intravascular edema. That is the reason why one major complication that you have to always be anticipating in these children is a sudden pulmonary edema presentation, because intravascularly the child is volume overloaded. Second point is that renal failure is there for the first time. Macrohematuria, previous discussion, I did not tell you renal failure. When there is renal failure, you can expect hyperkalemia. So always be wary of hyperkalemia. Third, hypertension. And this hypertension at any point in time can go into crisis. If you have been a good house surgeon in a good pediatric unit, you will be aware of this, that any time a child with nephritic syndrome gets admitted, what the pediatric PGs tell us is that the eventual outcome of this condition is going to be excellent, but you have to sit with the child that whole day. You have to keep monitoring BP and keep recording it on the chart, because the child can have hypertensive crisis anytime. You have to check potassium twice a day, and you have to be always sure that the child is volume replete and not volume overloaded. Okay, so this is how acutely this disease presents. Do we need to give anything specifically to the child? Nothing we need to give specifically to the child, and this disease will actually speaking go away. You have to call the child back at 8 weeks. Okay, you have to call the child back at 8 weeks. Why are you calling the child back at 8 weeks? Because C3 is going to be transiently low in this child. C4 is going to be normal. C3 is going to be transiently low in this child in around 90% of the population. And the C3 will normalize in 8 weeks. It is not a permanently low C3. C3 will normalize in 8 weeks. So you're calling the child at 8 weeks to see for serum C3 levels. If the serum C3 fails to normalize, okay, if serum C3 fails to normalize, that is an indication for biopsy. So when do you do biopsy? Means if C3 fails to normalize in 8 weeks. Correct? Then biopsy is always done keeping in mind a disease condition called C3 glomerulonephritis, which is now called as, which was previously called MPGN type 2. Now this is no more called MPGN type 2. This is the C3GN that we're talking of. Okay, and C3GN, final details with respect to that and all may not be asked at a Neet level, but we have done a module again on that. But you can get those points from there. But right now, just keep in mind that it could be C3GN. Biopsy, you have to be doing to rule this out. Second point is if there is a recurrent